Hi, my name is Monica Gambalato. I am a student at University of Southern Maine, and today we're going to discuss the topic of hypertension. Our objective for this topic would include um, presentation of a case, definition of hypertension, definition of hypertension guidelines. I would also present modifiable and non-modifiable risk factors of hypertension, and I will also present the effect of hypertension on the body. I would also include the patient care plan for this case, and in the case plan, we would include the pharmaceutical and non-pharmaceutical treatment for this specific patient. For our case today, we have a 44-year-old white male. He weighs 189 pounds. He is 5'9". His past medical history includes hypertension and migraine. He was diagnosed 9 years ago with hypertension. 6 months ago, he went to the emergency room for shortness of breath. He currently has no known allergy. His chief of complaint is headaches that keep him from work. His current vital signs are blood pressure 147 over 82, heart rate 76, respiratory rate 17. He is 96 on room air for oxygen. His family history includes his mother, who is 80 years old and has diabetes. His father is 82 and has hypertension. There's no medical history on his grandparents at this time. The medication that he's currently taking is diltiazem, CD 120 milligrams daily, and Imetrix 50 milligrams PRN daily for his migraine. His social history, he is a software engineer, and he has three children, ages 16, 12, and 10. He's been married for 20 years. The patient has um, complained that or suggested that he has tried beta blockers in the past that were ineffective, and he is currently reporting a headache pain that is 5 out of 10. He denies chest pain. He reports that he drinks 2 to 3 drinks per week. He denies illicit drugs. He has no history of cigarette smokes, but he does admit to vaping on occasion. Upon examination, I have heard crackles in his lungs, no history of heart failure, no shortness of breath. At this time, he does demonstrate with edema on his lower extremity. Hypertension is the most common cardiovascular disease in the US. It is the leading cause of mortality and morbidity worldwide. It accounts for cardiovascular death um, than any other modifiable cardiovascular disease risk factor. For the purpose of this presentation, we're going to be talking about 2017 hypertension guidelines. There are other guidelines out there, but for the purpose of this uh, case, we are only going to cover 2017. And the 2017 categorizes hypertension into 4 different categories, which includes normal, elevated hypertensive 1, stage 1, hypertension stage 2. And depending on where the patient falls and whether the patient has had cardiovascular disease, then the treatment would be based on that. And it would either include non-pharmaceutical or pharmaceutical treatment or both. So for normal blood pressure, for the normal category, these patients fall in the range of systolic blood pressure of 120, less than 120 over 180. These are less than 120 over 80. And these patients, we just want to promote optimal lifestyle. So we want to make sure that these patients are exercised. We wouldn't do anything with this patient. The patient who are in the elevated category, which are presenting with blood pressure of 120 to 129 systolic and diastolic blood pressure of less than 80. These patients, again, if they're presenting with coronary vascular disease, we would include we wouldn't include any drug therapy with these patients. We would just monitor those patients uh, cautiously. We want to make sure that we're um, paying attention and making sure that they don't go higher than that. Stage one is when we're really trying to make some adjustment. So stage one would include those individuals who are ranging in 130 to 139 systolic and 80 to 89 diastolic. And these patients, if they've had coronary vascular disease, then we would add blood lowering drugs for these patients, and we would also encourage non pharmaceutical treatments such as exercise, change of diet, and such. Hypertensive or hypertension stage 2 would include those patients who have greater than 140 systolic blood pressure and greater than 90 diastolic pressure. We're really worried about these patients, and we want to make sure that we are adding drug treatment in addition to non-pharmaceutical treatments such as exercise and change in lifestyle, as I've mentioned before. So when we are assessing hypertension or when we're assessing blood pressure, we want to make sure that we're taking blood pressure that is documented at least 2 times. So this can be taken in hospital or outpatient therapy. We want to make sure the patient is relaxed because, you know, anxiety increases blood pressure. We want to make sure that the patient or some settings would ask the patient to empty their bladder because that can impact their blood pressure as well. And we want to make sure that the patient's arm is below their heart when we're taking those blood pressure. Hypertension is often called the silent killer. It really impacts the whole body. It leads to various diseases, including coronary artery disease, heart failure, AFib, peripheral vascular disease, and many others. There are risk factors that make other people more keen to getting hypertension, and these risks are non-modifiable. So these risk factors include individuals who have chronic kidney disease, individuals who have family history of hypertension, individuals who are at increased age or those who are elderly, patients who are living in low SES. Educational status also impact your rate of getting hypertension, and believe it or not, being a male impacts your chances of getting hypertension. Some of the risk factors that patients can modify include just management of cigarette smoke, um, individuals who are exposed to secondhand smoke are at increase of hypertension, but these are things that can be modifiable. Patients with diabetes mellitus, patients who have dyslipidemia, um, patients who are overweight, uh, individuals who are not physically active, and those who um, are can't really manage their diet or have unhealthy diet. These are risks that can be modified so that your chances of getting hypertension is lowered. But if these factors are not modified, then you are at risk of getting hypertension. I have stated previously, hypertension really has an impact on the whole system, your whole organ. It impacts your brain. It increases your chance of getting aneurysm. Just the long-term damage, of the artery wall leads to aneurysm. It leads to problem with memory and understanding. It leads to dementia. Um, it leads to sleep apnea, blurred vision, chest pain, um, abnormal rhythm of the heart. It can lead to left ventricle hypertrophy, just the pressure of constantly the resistance on your heart. It leads to kidney damage, heart attack and stroke, heart failure. It leads to artery damage. It leads to hardening of the arteries, erectile dysfunction, and for women, it leads to vaginal dryness and lower sexual desire, in addition to blood clot and osteoporosis. So you can really see the overall impact of what hypertension can do if it's not treated properly. Because hypertension is not a standalone disease, there are many other diseases that are usually underlying hypertension. So the diagnostic for this disease includes many different labs that are taken, which include 12 lead um, ECGs that assess the heart to make sure that the heart is functioning properly, to make sure that the patient doesn't have left heart failure. We do urine analysis, blood glucose, and hematocrit. Blood glucose to really check if the patient has diabetes. Serum potassium to make sure the kidney is functioning. The same with creatinine and GFR to make sure that the kidney is functioning correctly. Serum calcium, just to make sure that there's no other damages like osteoporosis. And we also do lipid profile to make sure that it's not related to hyperlipidemia or like high cholesterols. So these are the labs that are usually taken to determine. The pharmaceutical treatment for patient with hypertension include drug classification that includes ACE inhibitors, angiotensin 2 receptor blocker, diuretic, beta blocker, calcium channel blocker, central acting drugs. And we're usually trying to introduce these drugs for patients who are in stage 1 and 2, according to the 2017 Hypertension Guidelines, in addition to non-pharmaceutical treatments such as weight loss, perhaps, depending on whether the patient has had or has cardiovascular or other disease. The goal of treatment for hypertension is to really prevent the rise of hypertension with age, because we already know that as a patient ages, their risk of hypertension goes up. We want to improve control of hypertension, and we want to make sure that the patient's target goal is below 130 over 80. We want to recognize that hypertension is not the only issue usually. And we want to encourage lifestyle modification and recognize that for some people, access to care is not a privilege. For some people who are living in lower SES, they might not have the chance of seeking medical care. So just as goal of treatment, we want to consider all of those factors. When a patient is coming to the office, we have to consider many factors or many things. First of all, we want to make sure that when we're setting blood pressure goal, we're setting it based on the individual. We want to make sure that they're able to follow through with their goal. And when we're lowering blood pressure, we want to make sure that we're not lowering the blood pressure very quickly, because it can produce other effect. And we also want to titrate medication. So if we're getting patients out of medication, we want to make sure we're titrating that. We don't want to automatically assume that the drug is causing the issue. So if a patient comes with a complaint of something, we want to really assess to make sure that it's not something else. Um, some of studies are saying that multi-drug treatment is better at improving blood pressure than single drug treatment, but you really have to think about adverse effect and side effects of medications. If you have more than one drug, then it's really difficult to assess whether it's like one drug or both of the drugs that are causing the side effects. We also want to make sure that the edema, because a lot of the time patients are presenting with edema. We want to make sure that that is controlled um, in the whole achievement of blood pressure. Let's go back to the case that I presented earlier, and let's try to discuss more about this patient. In the following slides, I'm going to break down this patient's case and see what we can do. This patient, some of the things that stand out to me is just his weight. His weight is pretty high for his height. His BMI is 27.9, and he's in that overweight category. His mother has diabetes, and his father has hypertension, so that already puts him at high risk. And we're just gonna look at his medication and assess some of the things that can be an issue for him. So the objective and subjective report will be presented in the slides. Some of the subjective report that the patient has stated includes the fact that he has tried beta blocker, but they were not effective. He has reported pain of 5 out of 10. He currently denies chest pain. He has reported that he drinks 2 to 3 drinks per week. He has reported that he does not do illicit drugs. He has no history of cigarette smoking, but he does vape occasionally. And the objective report based on my assessment include his current blood pressure of 147 over 82, heart rate of 76, respiratory rate of 17, and 96 for room air on oxygen. He has crackles in his lungs, no history of heart failure, no shortness of breath, and he does present with edema in his lower extremities. So the current medication that he's taking, like I've stated before, is diltiazem CD 120 milligram daily, Emitrix 50 milligram PRN daily. He has reported that he's taken beta blocker in the past. So I'm really going to talk about those 2 drugs and just dive more deep to see if these drugs are really complementary to this patient. Diltiazem is also known as cardizem. It is a class 4 antiarrhythmic medication. It is used for treatment of hypertension and angina. The drug works by inhibiting transport of calcium into myocardial or vascular smooth muscle. It inhibits the excitatory contraction, resulting in systemic vasodilation and decreased BP. The drug is metabolized in the liver by cytochrome 450. It has a half-life of 3 hours and a half to 9 hours. Some of the adverse effect of this drug includes peripheral edema, heart failure, headache, dysuria, hypotension, and weight gain. Some of the safety measures that we need to pay attention with this drug diltiazem is the effect that it has on the kidney, the liver, the blood pressure. we want to monitor BUN and creatinine to make sure the kidney is functioning properly. We also want to monitor liver functional test. Um, we want to monitor the patient's heart rate, and we want to make sure that we are monitoring the patient's heart specifically to make sure that there are no damages to the heart. The other drug that this patient is taking is Imitrex. This drug is used for his PRN headache medication, and this drug is also known as somatriptan. It's used to treat headaches and migraine. The drug works by activating vascular serotonin, and it produces vasoconstriction. It is metabolized in the liver by the cytochrome 450. It is excreted in the urine and feces. Some of the precaution that and the contraindication of this medication includes uncontrolled hypertension or patient with hypertension and PVD. So this already tells me, makes me question why this patient is taking this medication, because he has hypertension and this drug causes vasoconstriction. We're trying to inhibit that. We're trying to promote vasodilation because he has hypertension. Some of the adverse drug effect is hypertension, severe hypertension crisis, MI, coronary vasospasm, subarachnoid hemorrhage. So this is another form of stroke. So this drug really should be put into question for this specific patient, because it seems like it's contradicted to what we're really trying to achieve with this patient about his blood pressure. Some of the things that we want to bring into the attention of this patient with Imitrex specifically is the cost of the drug. The drug costs $708 for just about 9 tablets. I'm not sure if the patient is aware of that. We also want to include patient teaching about the adverse reaction of this drug, and perhaps talk about the symptoms that he's experiencing right now to see if it's a result of taking this drug. This medication has specifically said it should not be used with patients with hypertension. So I'm not really sure why this patient is taking it in the first place. So we really want to educate this patient about this specific drug. So my plan of care for this patient would include sitting down with him and having a discussion about the medication that he's taking and the cost of those medications. I would really want to discontinue diltiazem because of the crazy amount of money that it costs. And also there are other alternatives that are as effective, such as lisinopril. I think this lisinopril would be a great choice because it's usually the first line of medication that is given for patients who have hypertension. I also would like to discontinue Imitrex because it's like contraindicated to this specific patient. This patient has hypertension. He does not need a drug that causes vasoconstriction. I want to talk to the patient about possibly adding hydrochlorothiazide in the future if lisinopril does not work with him. And I really want to monitor the blood pressure on this patient regularly. So I would want him to note his blood pressure daily to make sure that it's tracking in the right track. And I want him to report any adverse reaction that he gets from taking lisinopril. And I would also like for this patient to report his daily weight, because we want to make sure that the fluid is being flushed out of his kidney, that his kidneys are not really being damaged. as a provider, some of the things that I really want to hone on and some of the things that I really want to look at with this specific patient, and some of the things that I want to collect data on, um, include uh, getting lipid profile for this patient. I really want to see his LDL, his HDL, and his cholesterol and triglyceride. I want to make sure that this patient is not at high risk for coronary disease. Um, his BMI is significant enough for me to consider whether he has other underlying issues that we're not really paying attention to. His blood pressure is pretty high. We want to do urine analysis to make sure that this patient doesn't have protein in his urine, to make sure that his kidney is functioning properly. We also want to get some reading on his heart to make sure that his heart is pumping properly. And I want to really know more about the patient ejection fraction to make sure that he hasn't developed hypertrophy in his heart. To take the time to talk about the medication that I have suggested. Lisinopril is it's an ACE inhibitor. It's an antihypertensive agent. Um, it cost $70 for 30 tab as opposed to $1,000. And some of the adverse reaction um, would be hyperkalemia, BUN, uh, increased BUN and creatinine, cough, headache, and hypotension. We really want to monitor BUN and creatinine periodically with this patient, and we want to monitor hyperkalemia because that can impact the heart. We also want to monitor the patient's blood pressure, obviously, to make sure that it's having an effect on the patient. The other drug that is used for hypertension is called hydrochlorothiazide. It's a diuretic. It works at the distal convoluted tubule and it causes the patient to urinate. This drug can be used alone or it can be used with a combination of other drugs such as ACE inhibitor. Its adverse effects include hypokalemia. We want to monitor the patient's electrolyte and heart function. And we want to make sure that the patient doesn't have hyponatremia, hyperkalemia, headache, or hypertension. These are the adverse effects of the drug. The drug costs about $19.78 for the 12.5 milligram dose for 30 tabs. So it's a lot cheaper than the medication that he's taking, which again is over $1,000. So this is one of the medication treatment that we would offer to this patient, and potentially pair this drug with other medication if a single drug is not beneficial for this patient. Some of the things that we want to consider with this patient would include non-pharmaceutical intervention as well. So that would include modifying of his diet. We want to make sure that the patient has reduced sodium intake and that he's increasing his exercise. So we want to make sure that patient is doing aerobic exercise or brisk walk. We also want to monitor. We also want to educate the patient about his alcohol intake. As presented, the patient says he consumes about 2 to 3 alcohol a week, which can be an issue if a patient has hypertension. We want to encourage the patient to reduce his weight by at least 10 pounds. This can help his blood pressure tremendously. We want to make sure the patient follows the DASH diet, which includes eating more fruits and vegetables, low-fat diet, high fiber, and lean meats, and also educate the patient about avoiding high fat and cholesterol. So these are the recommendation that would be suggested for this patient in addition to his pharmaceutical treatment to make sure that he is really he's successful in the treatment that he has.